Hello and welcome to today's webinar, Population-Based Payments in Medicaid, Strengthening Provider Incentives to Transform Care, made possible by Arnold Ventures. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. There will be a moderated question and answer session during today's presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. A brief online evaluation will pop up on your screen following today's event. Your feedback is very important to us, and we hope that you'll take a moment to complete this survey. I'll now turn the webinar over to Rob Houston, Director of Delivery System and Payment Reform at the Center for Healthcare Strategies.
Thank you, Travis. And next slide, please. Thank you, everyone, for joining us today to talk about population-based payments. We have a pretty lengthy agenda today. We'll do some welcome and introductions. We'll have some introductory comments from our generous funders at Arnold Ventures. And then we'll dig into what exactly is population-based payment, which is a critical question if we're going to have this webinar today. And then delve into a report that we authored titled Medicaid Population-Based Payment Models, Early Insights and Considerations for Policymakers. You may have seen it on our website already. Might have led you to this webinar today. But we'll share our early insights and considerations from that research. Then we are very much looking forward to a panel discussion exploring population-based payment models in Colorado, Massachusetts, and Pennsylvania. And then, as Travis mentioned, we'll get you all in the audience, submitting questions and hopefully answering them. Next slide. So if you're not familiar with the Center for Healthcare Strategies, we are a nonprofit organization that is dedicated to strengthening the U.S. healthcare system to ensure better, more equitable outcomes, particularly for people served by Medicaid. We work with our partners to advance effective models for prevention and care delivery, efficient solutions for policies and programs, and equitable outcomes for people. We believe that population-based payments have the potential to do all three of those things. Next slide. So you've met me already. My name is Rob Houston, Director of Delivery System and Payment Reform at CHCS. I'm joined today by my colleague, Ann Smithy, a program officer from CHCS, who will be doing most of the talking on our webinar, at least from the CHCS side. We're also joined by Amber Burkhart, a healthcare manager for Arnold Ventures and our partner from Arnold, who will be speaking in a few minutes. We will also be joined, we're very happy to be joined by three folks from Colorado, Massachusetts, and Pennsylvania: Trevor Abeda, Martha Farlow, and Janice Walters. I will introduce them more in detail when we go to our panel discussion. Next slide. So now I will turn it over to Amber Burkhart from Arnold Ventures for some introductory comments. Amber?
Thank you, Rob. As Rob mentioned, my name is Amber Burkhart. I'm the manager of Arnold Ventures Provider Payment Incentives Portfolio, which focuses on accelerating the adoption of population-based payment models. And we see these models as a promising way to give providers stronger incentives and greater flexibility to deliver high quality, less costly, and more equitable care. We've been thrilled to partner with CHCS over the past year to evaluate state approaches to designing and implementing these models in Medicaid. And for those of you that are not familiar with Arnold Ventures, we are a policy-oriented philanthropy focused on maximizing opportunity and minimizing injustice through strategic investment in a number of issue areas. Our healthcare portfolio addresses issues from reducing the high cost of drugs and high prices in the commercial sector to improving healthcare for dual eligible populations and advancing payment reform. And before I wrap up, I'd like to thank Rob Houston, Ann Smithy, and Kelsey Breichman for their work over the past year and for organizing today's webinar. I'd also like to thank our speakers for taking the time out of their busy schedules to share their on-the-ground experience in designing population-based payment models. And last but not least, thank you all for being on today's call. And we are excited to get going. So with that, I'll turn it back to Rob.
Thank you, Amber. And thank you again for Arnold Ventures support and partnership throughout this effort. So the big question today is, what is population-based payment? We need to know that in order to move on with this webinar. And if the next slide. Well, one way you can learn a little bit about what population-based payment is check out our new report, which is conveniently located at chcs.org. It's called Medicaid Population-Based Payment, the Current Landscape, Early Insights, and Consideration for Policymakers. It will answer your question of what the PBP model is. It offers a analysis of the current Medicaid PBP landscape and current Medicaid PBP approaches. It also has 6 state profiles for the 3 states that we will be talking to today, plus 3 other states, and also a handy table comparing state models. So if you haven't checked it out already, please go to chcs.org after the webinar and take a look. Next slide. Now, we can't wait for everyone to read the report. It's pretty lengthy. So I'll just share our definition for what a population-based payment model is. Now, there's many different definitions out there about population-based payment. Our definition that we used for our research was an upfront prospective value-based payment model that includes provider accountability for both quality and cost of care, and is based on the number of patients a provider serves, as opposed to the number of services a provider performs. It really is moving away from the traditional fee-for-service architecture. We also have acknowledged hybrid population-based payments, which are VBP models where providers are reimbursed through a mixture of the existing fee-for-service payment model and a population-based payment. In this model, fee-for-service rates are decreased in response to the addition of the capitated payment. So just having a care management fee on top of the existing fee-for-service model would not qualify for a PBP as a PBP payment in our book and many other folks' book as well. So our research focused on 3 types of population-based payment models. Things like bundled payments might be considered population-based payment models, but they weren't covered in our research. We focused on primary care PBPs, hospital PBPs, and total cost of care PBPs. Next slide. So why are population-based payments important? Well, quite simply, this is it. Population-based payments are the end state of value-based payment reform. If you look, I have the Healthcare Payment Learning and Action Networks framework up there. You'll see category 4 for population-based payment. There is no category 5. This is the end of the road. Back when the ACA was being rolled out and implemented 10 to 12 years ago, this was the vision for what this was going to be for value-based payment. The reason for that is it really maximizes incentives to move away from volume-based fee-for-service architecture. Now, not all providers may be able to get there, and not all providers maybe should be able to get there. There might be some that are doing value-based payment in a different way. But category 4 payments, population-based payments, offer the greatest opportunity to achieve elusive healthcare goals, such as improving costs, quality, health equity, patient and provider experience, and population health. Next slide. And while there are lots of benefits to population-based payment, there are also some challenges, and we need to acknowledge both to discuss this. So the benefits are aligned financial incentives for providers, payers, and patients. It offers flexibility for providers to treat patients the best way they know how, rather than only what they can bill for. Population-based payments are usually paid via per member per month payments, and these type of payments offer budget predictability for both payers and providers, and as well as financial stability for providers, which is very much appreciated by especially safety net institutions and providers that take Medicaid. It's also a straightforward design. It's not complex like other VBP models, like a shared savings approach. It's a per member per month payment if it's a full PBP. There are some challenges, though. One of them is the barriers to entry. These are advanced payment models, and sophisticated providers need to be ready to perform these services provided. They need to have experience with VBP and often need to have analytic capabilities that are top-notch. Providers are also expected to take on significant financial risk as part of a population-based payment model. And from a state perspective, if a state is implementing a population-based payment model, it might limit the participation for the providers in the state because it is an advanced model, at least at first. There's also the potential for perverse incentives. Like any payment model, fee-for-service has a lot of different perverse incentives in its purview. And the predictable revenue stream that is also a benefit of the PPP model does create the incentive for providers to withhold care or engage in adverse selection of healthier patients, unless the PPP model has the appropriate quality metrics and other design elements in place to mitigate those incentives. And finally, while we expect that in the long term, the administrative burden will be less under population-based payment, in the short term, there will likely be an increase in administrative responsibilities and change management that will require some more short-term efforts. Next slide. So that is it for me for now. I am happy to turn over the mic to my colleague, Ann Smithy, who will discuss the early insights and considerations that we found in our research. Ann?
Yeah, thank you, Rob. I'm excited to be here today to talk to all of you about some of the things we found while working on this report that Rob mentioned. Population-based payment models are still fairly early in Medicaid, but as you can see from the title of our report, we think there are some great insights and considerations to share with you all today. So next slide. When we were working on our report and interviewing different states and stakeholders who care about PBPs across the country, we learned a lot about different factors that are part of and influenced Medicaid PBP design. And those include contextual or environmental factors, and then the actual design elements or decisions of these PBP models. So there are a bunch. We don't have time to get into all of them today, and I'm just going to highlight 5 key factors, the ones with the green stars next to them in this table. And I chose those 5 because these are factors that are really specific and more unique to population-based payment as opposed to other value-based payment models. So you can see, engaging stakeholders, getting buy-in to a VBP model is critically important, but that's something states have experience with across all types of value-based payment models. On the other hand, regulatory barriers specific to PBPs or determining provider readiness to move into a model with far greater cost and quality accountability that they might be used to, those are a lot more unique to the population-based payment environment. With that in mind, we'll go ahead and get started highlighting these 5 factors. And if you're interested in learning about the rest, we hope you check out our report. And so on the next slide, we'll get started thinking about navigating regulatory issues. And so many of the states we talked to noted that regulatory barriers to moving off of fee-for-service and into population-based payment were some challenges and delays that they faced when getting these programs off the ground. And getting approval is even more challenging in states with a fee-for-service delivery system for their Medicaid program rather than a managed care delivery system. And that's because the regulatory path is a little bit less clear for those states. So we know managed care states have a bit more flexibility, right? They contract with their MCOs and they can tell their MCOs how to pay and contract with providers. Whereas states in fee-for-service delivery systems without that managed care sort of middle ground have a little bit more difficulty thinking about how to move into population-based payment. So our key consideration for policymaker here in navigating regulatory issues and kind of just getting approval from the federal government is to think about how CMS can encourage development of new PBP models. And we know CMS is interested in increasing accountability in healthcare, and so a great goal for them to pursue. And there are a lot of different ways they can encourage development of these models. So they might consider releasing additional guidance on sort of just a roadmap of how to get approval for these models. And like I just mentioned, that'd be particularly valuable for states with fee-for-service delivery systems. They might also be interested in designing new CMS Innovation Center models that focus on population-based payment. So while this isn't always it isn't always a super easy path, states that participate in CMS Innovation Center models typically have an easier time getting approval moving into a new payment structure than states that aren't. And so models like CMS's Primary Care First model, which is a primary care PBP, or their CHART model, which is a rural hospital PBP, can be a helpful way both for states to get this regulatory approval, but also for states to just gain a little bit more experience in a PBP that's got some pre-built design features that can help them learn what they like and what they can succeed in. And finally, CMS could consider creating new waivers or waiver flexibilities specific to adoption of PBPs. They've done so before with things like the DSRIP 1115 waivers, and they could do so again if they were interested in seeing a lot more PBP models across the country in Medicaid programs. And so on the next slide, once you've gained approval, it's important for states to think about how to prepare for change and see if their providers are really ready to move into these models. So as Rob mentioned, one of the challenges of these models is that they're pretty new and that they require providers to do different things and take on a lot of new responsibilities. And so one model we spoke to and we profile in our report is New York State's VBP Innovator model. This, I think, is a great example for thinking about provider readiness. So provider organizations in that model, which is a total cost of care PBP, need to take on care delivery transformation. They need to think about changing how they deliver care to meet the cost of care goals in their PBP, as well as quality goals. They also take on new administrative responsibilities. So in negotiation with the managed care organizations they contract with, providers in New York's VBP Innovator model take on things like utilization management, utilization review, and other capabilities that are usually the purview of a managed care organization. So while not all states would necessarily go that far with moving administrative effort from the MCO to the provider, it's certainly true that in all PBPs, providers are taking on more administrative work as they take on more responsibility for whole person care and outcomes for the patients on their panels. And last, provider organizations have to take on more financial risk management under a PBP. This is a model that really changes how providers are paid, and that thinks about providers as having far greater cost accountability than they've had before. And so organizations need to take some time figuring out how they'll handle that risk and make sure that their finances stay stable. The benefit of PBP with having stable and consistent payments is certainly helpful as providers think about financial risk management. And so policymakers, and in particular states who are thinking about PBPs, should really consider how they can design their models to appropriately meet the level of readiness that providers have in their state. So if you are a state out there who's interested in PBPs, you might first want to start thinking, all right, so what kind of VBP models have providers in my state participated in, and have they been successful? Are they ready to move on to greater cost and quality accountability, or do they need a little more practice in a VBP model that's maybe a bit less advanced, with a long-term plan for the state to move towards population-based payment? Once you've done that holistic look at assessing provider readiness, states also spend some time often thinking about if individual provider organizations are ready to participate in these kinds of models. And so in New York State, which I was talking about earlier, provider organizations need to apply to the state to get permission to operate as a VBP innovator. And so the state does a pretty hands-on readiness assessment. Other states might do a less hands-on readiness assessment and let providers self-opt into models or choose if they're ready to participate in a PBP or not. So that decision really depends on whether states prefer to be more or less hands-on, what kind of capacity they have, or how complex they think their model is for provider organizations. States can also think about increasing provider readiness over time. So if you're not sure your providers are ready yet, there are steps you can take to move them towards PBPs and all the great benefits and advantages Rob talked about earlier. And so that might look like things like group learning activities or upfront capacity building funding to help providers learn how to change how they deliver care or invest in new capabilities to deliver care differently. And there's a real health equity consideration here when we're thinking about provider readiness. So we know from research and strategic documents CMS has been releasing over the last year that safety net providers are much less likely to participate in value-based payment models than non-safety net providers. And so this is partially because these kinds of providers may have less capacity and fewer resources to really succeed in these kinds of models. And they may be treating more complex patients with higher needs and worry about whether they can meet quality goals of different kinds of VBP models. And so States who are thinking about health equity and want to make sure these organizations that prioritize focusing on underserved patients and people who face inequities are able to participate in these models can focus their readiness efforts and moving towards readiness on safety net organizations. So as we think about provider readiness, it's very related to the idea of transitioning into a PPP model, which is on our next slide. So it's a big change to move into population-based payment. Like Rob said, it's moving off of a fee-for-service architecture, paying based on billing codes, and moving much more into having responsibility for a set panel of patients and meeting their needs, whatever they are, within your financial, within one financial arrangement. And these models are new, not just to providers and thinking about provider readiness, but also to all of the stakeholders who participate in value-based payment. In managed care states, MCOs and providers have to learn how to share responsibility and negotiate with each other under these new payment arrangements. And in all Medicaid programs across the country, Medicaid agencies are also learning, right? They're learning how to design population-based payment models, how to define their goals, and how to measure success. And so a key thing to remember there is that these models are new and it's going to take time to see results. You can't expect a huge change in quality or a huge change in costs immediately. And as you learn and other stakeholders within the model learn, you will have more chances of success and the opportunity to refine and implement changes to the model to make it more successful. And so with that in mind, states that we spoke to in putting together this report noted that multi-year timelines to implementation are common. Many states started designing their models a few years before they went into their first phase of launch. And many states with PBP models that are already active right now are spending time thinking about what's their year or 2-year plan to change and improve these models, given what they've learned in the first few years of participation. And so policymakers talked to us about developing an on-ramp, which can look really different in different states, but includes a lot of familiar ideas from throughout value-based payment work, like starting with a year that's reporting or measurement only, so you can gather a baseline and providers can learn more about what's being measured and how are we doing on these measures and how can we do a little better. It can include, like I mentioned previously, upfront funds to build capacity. So providers can say, oh, we serve a lot of patients who have social needs. Can we use some of these fundings to hire a social worker or community health worker? And it can include group learning opportunities. So providers can learn from each other about how to assess the needs of their population and make sure that they can maintain financial stability, streamline and provide more efficient and cost-effective care while keeping their quality high. And many of the states we spoke to also had put into place a hybrid model. So that's that model where reimbursement is made partially as fee-for-service payment and partially as a PBP. And these kinds of models can be part of a transition phase. So moving providers slowly over time from fee-for-service towards PBP with different levels of hybrid payment throughout. Or it can be the final design. So some states and some VBP thinkers think that there are incentives in both fee-for-service and PBPs, and putting them together gets you the best of both worlds. Good incentives on some sides to say provide higher volume of preventative care with fee-for-service payment, but to provide more streamlined and efficient care with population-based payment. So states, when they're thinking about transitioning, can consider this. And I think a great example of this hybrid model is Washington State's model. They are putting together a primary care PBP, which is expected to launch in the near future. And they start their primary care providers out in a hybrid model with a goal to move them towards full PBP over a handful of years of participation in the model. And so you can also learn more about Washington in our report if you read it after this presentation. And so on the next slide, we'll think a little bit more about doing the math. So one of the biggest challenges of putting together a great PBP is setting rates. You have to think about what are we paying for and how do we pay the right amounts? And of course, are providers going to feel like the rates that we're setting are fair for covering the cost of care they're delivering? And so many states right now who are participating in PBP models are actually reconciling their population-based payments back to a fee-for-service baseline. And a lot of these models do so because of regulatory requirements. But we wanted to point out that there are trade-offs in this kind of reconciliation model versus a model that really breaks free from a fee-for-service architecture and moves fully into population-based payment. These trade-offs can include some pros for reconciliation. So reconciling back to fee-for-service with some sort of claims mechanism helps states see what care delivery is happening on the ground. And that can help create safeguards to stinting on care, which is one of those challenges or perverse incentives that's present in a PBP. But on the other hand, it can add administrative burden, making a model that should be more streamlined and administratively a lighter lift into something burdensome. And finally, they can limit flexibility of PBPs. So one of the great promises of a PBP is that providers can deliver the care that they think is right for the patient that's in front of them, instead of care that fits into a fee-for-service billing code. But if you're reconciling back to fee-for-service, some of that flexibility is diminished, which could mitigate the positive benefits of a population-based payment. Now, states have multiple options for setting rates in a PBP. They can think about historical utilization, so tying what providers get paid to what kind of care they've delivered and what they've been paid in prior years. They can think about optimal utilization, which ideally would think not about what care has been delivered, but what care should have been delivered. So that ideally gets to things like inequitable access to care or poor quality of care delivered over time. And finally, they can think about tying rates to average costs or some kind of cost benchmark. So a state with high cost variability between providers might want to move all provider costs more towards a state average, or a state with higher spending by far than the rest of the country might work on moving their provider organizations more towards a national average for spending. So there are benefits to each of these kinds of options for setting rates, and each of them also has implications in health equity. Particularly as I noticed with optimal utilization, that kind of a lens gives states the chance to think about what should be happening, ideally in healthcare delivery, and how can we work with providers who predominantly serve patients who experience health inequities to make sure they're getting paid a fair and appropriate amount to help meet the complex needs that their patients might have. And one other thing that can help provider organizations and states think about health equity when they're setting rates is thinking about good risk adjustment. And so we spoke to states who talked about both clinical and social risk adjustment as a way to make sure that their rates are accurately and fairly reflecting the needs of the patients that are being served in a population-based model. This can mitigate that risk of adverse selection where providers are a little bit incentivized under PBPs to work more with healthier and less costly patients and pocket some of those savings. So if the risk is adjusted properly, then providers will feel more confident working with more complex patients, knowing that their cost of care is covered by the rate of the PBP. And I'll just note also that social risk adjustment is one of those really interesting topics right now where a lot is happening. I'm not going to spend more time on it today, but our panelist from Massachusetts may be able to speak about it a little bit later, as Massachusetts is one of the 2 states in the country right now that's doing social risk adjustment in their payment to providers, organizations. All right, and in my next slide, I'm going to talk about my last topic for today, which is evaluating the population-based payment model. And so we need to evaluate these models in order to make sure we're getting it right. Like Rob said at the beginning of the conversation, PBPs really are the end of the road in payment reform. And so if we want to make sure that they're working the way we're hoping they are, we need to keep evaluating and keep sharing those results far and wide. But do PBPs work? Well, the answer right now is a little bit complicated because evaluations are limited. A lot of models in population-based payment are pretty new. So they're within a few years old. Maybe they just got launched this year. Maybe they're still in the design phase and are going to be launched in the next couple of years. COVID-19 also impacted ongoing evaluations. I'm sure that's a common refrain in these types of webinars, but states that had started to see patterns had those patterns hugely disrupted over the last few years and might only now be getting back to evaluations that meaningfully show the impact of their payment models. But we do have evaluations from some states, in particular states that have participated in federal partnerships to build their models, or states that have a Medicare or multi-payer component to their PBP. And these results show, or these evaluations show that results vary among states. Some models have shown really promising results on cost control, quality improvement, and patient experience, but not all models have shown those outcomes. And one model I do want to highlight is Maryland. So they have an all-payer population-based payment model. And the Medicare component of their evaluation has shown really promising results. They've had great successes on cost control, on quality improvement, and patient experience. And so we know that there is some promise in PBPs to achieve these multifaceted goals that we're looking towards for them to work on. And so with this in mind, the lack of evaluation and the fact that we want to learn more, we want to learn how different scope of PBP impacts their success. We want to learn how different design factors can make them more or less successful. We would love to see policymakers prioritize evaluation for their PBPs. So think about designing models that have an evaluation component built in. And we'd love to see the federal government consider other opportunities to support evaluation of PBP models. Since we know that the models right now that exist with robust evaluations, it's typically because of federal partnership that helps fund evaluations. And finally, and we know states and CMS already have an eye on this, so we're excited to see that and hope it continues. We should be thinking about how we can evaluate the health equity impact of PBP models. So historically, we've looked at average quality and cost of care and experience, but we haven't always looked at how value-based payment and PBPs in particular impact health equity. We think there's great promise there as we learn how PBPs can help providers personalize care and how setting the proper rates can help providers feel confident taking on complex patients. And so we are looking forward to further evaluations related to health equity. And so these are some of the key things we found in working on our report related to population-based payments across the country. It was an exciting project. We learned a lot, and we're really happy to have gotten to share it with such a great audience today. And now I'm excited to pass the conversation on to our panel. So on the next slide, I'll introduce the panel briefly. So Rob, I'll turn it to you to introduce panelists from Colorado, Massachusetts, and Pennsylvania who will be speaking about their state models.
Thank you, Anne. Very informative. So Anne is right. We have three great panelists today to discuss some of their experiences with implementing population-based payment models. And I've been monitoring the Q&A questions in the chat. A lot of the questions you had are going to be answered in this panel. So we have three states here that have really promising PBP models of varying scope. We have Colorado, which has a new primary care population-based payment model, Pennsylvania with a hospital-based model, and Massachusetts that has a total cost of care model, and that they will soon be supplementing with a primary care PBP model. So we have all three bases covered that we were looking at. So our panelists today, Trevor Abeyta is the Payment Reform Section Manager at the Colorado Department of Healthcare Policy and Financing. Trevor's team leads the agency's shift to value-based care. Under his leadership, Colorado Medicaid has implemented a maternity bundled payment covering 25% of Medicaid deliveries and population-based payment for primary care providers covering 20% of Medicaid members in Colorado. We're also joined by Martha Farlow, who is the Deputy Director of Policy at MassHealth, which is the Massachusetts Medicaid agency. There, she oversees a broad policy portfolio related to managed care programs. Martha's leadership includes developing and negotiating MassHealth's 1115 waiver extension request, which was recently approved, designing and managing accountable care organization contracts and procurements, and advancing health equity and managed care policy. Additionally, Martha has led the development of MassHealth's primary care payment reform strategy, including supporting the development of a new subcapitation payment model to advance care delivery and move primary care away from fee-for-service incentives. And finally, last but not least, Janice Walters is the Chief Operating Officer at the Pennsylvania Rural Health Redesign Center, where she has been leading the rural health transformation efforts since May of 2020. She has been leading the efforts on the Pennsylvania Rural Health Model since 2018. In her current role, she is responsible for the model's overall implementation, including recruitment of stakeholders, methodology development, transformation planning, and oversight of technical partners. Janice is now also serving as the project officer to the Rural Emergency Hospital Technical Assistance work awarded to the Rural Health Redesign Center. Prior to leading these health transformation efforts in Pennsylvania, Janice spent 12 years in healthcare leadership positions, primarily in rural Pennsylvania, and her experience includes financial oversight of the rural health system's business activities, as well as its population health activities. So Trevor, Martha, and Janice, welcome. And if you could turn your cameras on, we can get started with the conversation. There you are. Great. So we are going to have, if we could pull the slides back up, each state will provide a quick overview of their work, and we've decided to go in alphabetical order. So Colorado, and Trevor, you are up first.
Thank you, Rob. And can you just confirm you can hear me?
Yes,
I'm living through a home remodel and it just reached a crescendo, so I'm headphones.
Okay, we hear you great.
Good, thank you. So thank you for having me here today. I really appreciate the opportunity to talk about Colorado's APM2 payment model. APM2 is our primary care partial capitation model. We are still a fee-for-service state. I think we're like one of 10 or 11 fee-for-service states in the country at this point. So that means that my team at Colorado is operating our APM2 payment model. It is not contracted out to a managed care entity. We are running the payment model. We designed it, we implemented it. So we learned a lot about population-based payments through this process. APM2 is still pretty new to us here in Colorado, and it began in January of this year. So we're nearing the end of our first performance period for APM2. It runs on an annual cycle in Colorado. The APM2 program is currently voluntary in Colorado, and we're covering about 20% of Medicaid members through the program. So we are moving to actually cover all Medicaid members through the program in Colorado by January of 2024. And I'll talk a little bit more about that later in my presentation. APM2 has two specific payment components. The first is a partial capitation. And what that partial capitation is a per member per month payment for a defined set of services, which are mainly your main primary care services like evaluation and management codes, plus some other services. And the primary care provider can choose to earn anywhere from between 0 and 100% of their revenue prospectively as that partial capitation payment. The reason we did a partial capitation, referring back to some of Ann's slides, is we recognize that not all providers in Colorado are ready for a full-blown capitation payment or a prospective payment. And so we wanted to give flexibility to providers to meet them where they're at with this program. We believe that the APM2 program in Colorado can provide consistent and stable revenue to primary care providers, and it's going to allow them to invest in innovations such as team-based care that generally are not reimbursable through fee-for-service. So we're really excited about that partial capitation payment. The second payment component is upside-only shared savings through chronic condition episodes of care, and there's 13 different chronic condition episodes. Why we chose chronic conditions was when we looked at our total medical spending, 83% of our total medical spend is spent on a patient with one or more chronic conditions in Colorado Medicaid. So there's a big opportunity for savings with a lot of avoidable spending. And the goal of the upside-only chronic condition episodes is really to increase investment above and beyond fee-for-service payment into primary care to create a stable system of primary care in Colorado for our Medicaid members. So we're very excited about the potential of this program in Colorado. And right now we have a legislative request in to actually increase what is being paid through that partial capitation payment by 16% to match our rates in Colorado Medicaid to the Medicare program actually currently. So it's a pretty big rate increase for providers who are joining the APM2 program. And as I previously mentioned, the other part of that legislative request is a request to enroll all providers, so all primary care providers in Colorado into the APM2 program beginning on January 1st of 2024. So our model's new and we do not have any results to share yet, but it being near the end of the first performance period, we are really looking forward to getting our first results in and learning how we can improve the program. So thank you, Rob, and I think I pass it to Massachusetts.
That is right. Martha, you're up. Thanks, Trevor.
Thanks, Trevor and Rob. So I'm excited to be talking today about Massachusetts' accountable care partnership plans. We have 2 accountable care organization models in Massachusetts. The ACPP is one. We also have a primary care ACO model. That's our other one. The ACPP, the Accountable Care Partnership Plan, is an interesting model in that it is a partnership between an MCO and a provider set. We introduced our ACO models for the first time in 2018, which marked a really large shift in sort of the way we think about care and value-based payment and quality and costs and all of those things coming together. And we're really lucky to have an amazing set of engaged stakeholders, plans, providers, advocates, members who helped us think about and design these models, which are authorized under our 1115 waiver. So our ACO models are voluntary, but we are a managed care state. When we launched in 2018, we had a total of about 800,000 people in ACOs, I believe close to 600,000 of which were in ACPPs. By 2020, that was up to 640,000. And today in 2022, with the increase in enrollment due to the public health emergency, we have about 725,000 members currently enrolled in our accountable care partnership plans in 13 different plans. So these plans really sort of run the gamut in terms of the providers that make them up. We've got some hospital-based ACPPs, we've got some community primary care-based ACPPs, some are large, some are statewide. We also have some more local and regional ones. But really, I think what makes these exciting is this partnership between the plan and the provider, where they are holding joint accountability for health outcomes, lower costs, and improved member experience. As Anne mentioned earlier, one of the things that we think about that we're excited about is our risk adjustment, where we account for not just medical, but social risk. And all of our capitation rates are adjusted based on social risk, which includes a factor that we call neighborhood stress score, as well as adjustments for homelessness and for living in a rural county. Our program has now been running for 4 or 5 years, which is very exciting. So we do have preliminary results. Obviously, some results are delayed in a large statewide ACO type program. The other issue that we have that, again, I'm sure is a theme for everyone here is that COVID really interrupted our evaluation. So we saw some promising early results in 2018, 2019. We saw increased connection to primary care. So primary care visits were up from 2018 to 2019, and were 12% higher for folks who were in ACOs than were folks who were not in ACOs. We also saw some impacts in preventable acute utilization. We had an 11% reduction in avoidable admissions from 2018 to 2019. Across the board, our clinical quality scores were high and rising between 2018 and 2019 on the majority of measures. We have 22 quality measures that we're tracking across our program. And also implemented some exciting programs like our Community Partners program in the community, as well as flexible services, wherein we paid for housing and nutrition supports for members that I think really helped our ACPPs sort of grow and blossom to what they are, what they have become. Our evaluation is sort of just now catching up to 2020, and those results are honestly a little bit hard to interpret. We saw some changes in quality scores. For example, across the country, pediatric vaccination was down. That was true in Massachusetts as well, but that we are assuming was largely attributable to people staying home, which was largely the safer choice, at least early in 2020. We did see a decrease in cost in 2020, but again, that is likely more attributable to overall decreases in utilization across the country, across the world, than likely because of the specific ACPP program. So still sort of working through how we think about those results, and looking forward to hopefully things normalizing a little bit more in the future to help us evaluate better. We have seen member experience results, which is part of our quality slate, sort of stay high, sort of in the 80s out of 100. Did slightly decline in 2020, but we know again likely some challenges going on in 2020. So I will stop here and pass it back to you, Rob, or over to Janice.
Yeah, thank you, Martha. Janice, you're up.
Sure. Thank you, Rob. Again, thank you for hosting this session and allowing us to speak to the programs that we're administrating in our various states. So I'm in the state of Pennsylvania. I'm overseeing the Pennsylvania Rural Health Model. This work did start within the Pennsylvania Department of Health, but then it did migrate to the Rural Health Redesign Center, an independent entity that was created in 2020. So we did start with a hospital-based program. Really the problem that we were looking to address is to provide an alternative solution for rural hospitals. So understanding that not unique to the state of Pennsylvania, we have rural hospitals that are in crisis. So there's every so many weeks a new article being published about the rural hospitals that are at risk of closure. And the state of Pennsylvania was not any different than the rest of the country. So we were fortunate enough to be given the opportunity to test an all-payer model in cooperation with CMMI, the Centers for Medicare and Medicaid Innovation, through again, a partnership to test a 7-year program that would look to basically achieve 3 things. One, increase the financial stability to rural hospitals that choose to participate. This is a voluntary all-payer program, but really goal 1 was to improve the financial position of participant rural hospitals. Goal 2 was certainly to improve population health results, that if we fundamentally changed how hospitals were paid for, or were paid for the services that they provided, could they then take their foot off the gas as it relates to generation of volume of services in exchange for payment, but really invest in population health. So the second goal is to improve population health within the rural communities. And then the third goal is to certainly impact or reduce the total cost of care over time. So as mentioned, as part of the Center for Healthcare Strategies research, they certainly identified that it takes time to really implement meaningful change. And so in order to see results and improved results, you certainly do need time because this is not easy. I'm sure as all of the states can attest that we're part of this, change is really hard. And really having to learn a new skill set is probably the most challenging thing that our hospitals face. So again, it's a voluntary model. We currently have 18 participant hospitals across the Commonwealth. Residing in those communities is about 1.3 million Pennsylvanians, of which about 235,000 are actually Medicaid subscribers, but because of the all-payer nature of the program, we estimate that we're impacting about 1.3 million Pennsylvanians. And really, why did we choose to focus on rural? The problem that we're trying to solve is really to ensure access to care remains in these communities. So as we think about health equity and trying to make sure we have equitable care, access to care to me is the foundation of equitable care. And if we don't have access to care in these rural communities, health equity and trying to make sure that equitable care is really hard to achieve. So we did start with a hospital global budget. Certainly there's been criticism to our program that, why did we start with hospitals? Why wasn't it a total cost of care? But again, because of what we were trying to achieve by keeping rural hospitals open, we felt it prudent to start with a hospital global budget to stabilize the financial position of the hospital. So as part of our goal, certainly measuring as part of our program, certainly measuring outcomes has to be part of that. So we do have a negotiated set of outcome measures that we've negotiated in cooperation with CMMI. Like all of the other programs I've already stated, COVID did prove challenging. Programs of this nature is hard enough to implement absent a pandemic, but throw a global pandemic on top of an advanced payment arrangement certainly does create additional challenges. But that stated, we are far enough in our program that we are able to see that from a health outcomes perspective, that we are meeting our measures as we measure ourselves against other rural populations across the state. Our quality metrics are either better than or consistent with the trends that we're seeing across the country specific to rural populations. So, in a nutshell, we can't, we're seeing favorable outcomes. Certainly our hospitals felt participation in this program certainly helped stabilize them in the midst of the COVID pandemic. Certainly a lot of testimonials from our hospitals that they were so glad that they chose to participate. And for the most part, because we're paying a global budget in exchange for a transformation plan, a formal strategic plan that basically says, in exchange for that global budget, what commitments are you looking to make as it relates to improving population health? Our hospitals have stated that they feel that it actually, for the first time in their healthcare careers, felt that it brought the hospital to the table as a partner as it related to improving the population health of the communities they serve. So, we are seeing favorable results. Certainly our focus now is on a path forward. Our program formally goes through the end of 2024 with a formal transition period. And certainly we're looking to advance the program because our participant hospitals have become to rely on it. And we certainly hear that loud and clear through the formal evaluation process that CMMI has engaged NORC to do a formal evaluation. And those, I would point you to those. I'm out on the CMMI website. There are formal evaluations out there on our program. And again, testimonials and certainly data is now beginning to come forth that shows that we are achieving our population health outcomes as well. So with that, Rob, I will turn it back to you.
Thank you, Janice, and thank you to Trevor and Martha as well for those overviews. So we just have a few minutes left. There are some questions, a lot of questions in the chat. If you have any last questions, please join them. Please submit them. I'm trying to cull them. There was a lot of questions in the chat about health equity. And Janice, you had mentioned how your model addresses health equity. Martha and Trevor, would you mind speaking to Massachusetts and Colorado's approaches?
Sure, absolutely. That's something that we've thought a lot about quite a lot and something that we are sort of still in progress on, working with the community, stakeholders, members, plans, providers, and have some exciting pieces that are coming up around health equity and some exciting initiatives that we'll be launching next year. We have thought about equity in particular in terms of access, like Janice said, as really the core foundation, as well as addressing members' needs that allow them to access everything else in their life. So we've thought a lot about social determinants of health and health-related social needs in the context of equity, with a focus on housing and nutritional supports. It's really hard for a member to access any kind of diabetes care if they don't have somewhere safe to go at the end of the day and somewhere safe to store their insulin. And so we've come up at it in particular from sort of that angle.
Great, Trevor.
And I can just add in what we're doing in APM2 is we're stratifying quality measure performance by race and ethnicity in this first year to determine where there are health disparities in quality performance. And then talking about in the future, how we can actually tie those disparities to payment. So I would say that we're in progress as well. And I always believe that we can be doing more in our payment models to address health equity. So this is a future consideration that Colorado is incredibly interested in and invested in.
Thank you. Janice, anything else you wanted to add on the health equity front?
Yeah, certainly. As we advance our program, focusing on social determinants of health is equally important as again, I think Our program has allowed our hospitals to think differently in terms of how they can actually start investing. A lot of times the rural hospital is not only the economic engine, but the healthcare engine. So certainly as part of their transformation plans, their strategic plans that they put together, addressing social determinants of health. Transportation is huge in rural communities because we don't have the public infrastructure. So even if there's food available, getting that food, if they don't have a vehicle to go get the food, that certainly is a barrier as well. So all that to say, access is the starting point, but really I'm encouraging our hospitals, and through our support, through the technical assistance that we've provided to them through the funding that's been made available to us, that has equipped our hospitals to step into spaces where they have not been able to really pay attention to before. So a lot happening on the health equity. Could do a whole conversation on health equity, but access is the beginning, and then making sure we have infrastructure in place to address the social needs of our patients.
Right. So there is more questions in the Q&A than I've ever seen for a webinar before. So we're not going to get to all of them. So I'm gonna close with a general question, and it's two-part for each state. What is the most exciting aspect of your state's model, or what you're most proud of? And also, what is the biggest challenge that you faced in implementing your model? Let's start with Pennsylvania. Janice, do you mind going first?
Don't mind at all. So the most exciting thing is the platform for innovation, and seeing the collaboration between our hospitals and our payers and all of the state agencies. So this is nothing that anybody can do alone. And so to see the collaboration and the relationships, that is just really exciting. And I would say the launching point, this is a start. We're still even very early in our journey, 5 years in, because it takes a lot to build relationships and the infrastructure and to learn new skills to think differently. So I think that ties into the greatest challenge is this does require completely different thought. And for most hospital leaders, they've spent their careers in fee-for-service, and breaking that and freeing them to think differently is probably the greatest challenge. And again, it takes a lot to pull this off. So I would say any state that is considering doing this, there's a lot of thought that needs to be given to the infrastructure that's needed. And to start those conversations sooner rather than later, but recognize that change does take time. Somebody already mentioned that in one of their statements. This is nothing that can be done quickly, and recognizing that having the patience, having the resiliency, and understanding that different skill sets, and having the patience to allow people to come along on the journey is also needed. So breaking fee-for-service is the biggest challenge when you launch into a value-based payment arrangement. So.
Got it. Thank you, Janice. Martha, do you want to go next?
Sure. I would echo Janice on the greatest challenge. I think one of the things that I certainly have learned over the past 4 or 5 years of this program has been how many systems that we interact with that are truly built on fee-for-service. It has been the way that people think about care. It has also been the way that our data systems and our payment systems and our provider credentialing systems and our workforce is all built. And so recognizing the time and the teamwork that it takes to slowly unravel those systems and build something better in its place, while making sure that we aren't losing anyone as we sort of make those changes. And these are very disruptive changes, but we need to make sure that there's continuity for our members during these changes, I think has been the biggest challenge. In terms of what's most exciting, I think it's really been the provider and community organization engagement for me and for us. The way that we design this population-based payment really put providers, and particularly primary care providers, at the center for I think the first time for a lot of them, and put them in a position of power to decide how they wanted care to be delivered and to be the home that they had wanted to be for the member. It also meant that they've been dealing with how to do population health in a very different way, and how to manage data and financials in a very different way. I was in a meeting with a provider this morning about primary care payment reform that we're thinking about and sort of following in Trevor and Colorado's footsteps. And he said, make sure that my payments aren't reconciled to utilization. That doesn't create the incentives that I want. And that was something I don't think I would have heard from the leader of a community-based primary care organization 4 or 5 years ago, who not just understood deeply what this would mean, but also was really advocating for this.
Thank you, Martha. Trevor, you want to take us home?
Sure, I'll be concise. So I think the most exciting part of our APM2 model is the ability to support primary care providers in Colorado with that 16% rate increase that we're proposing. This is a huge step in the right direction towards building a strong foundation for primary care providers to take great care of our members in Colorado. But that excitingness also brings a challenge, and that is the scalability of our current APM2 payment model. These payments, there's no way to get around it. They're complicated. And how you operate a population-based payment, the devil really is in the details. And when you think about how the state can sustainably operate this model at scale, your head just explodes. And so for us, it is really figuring out how we can do this in a way which supports our primary care providers in Colorado, but is also on a achievable scale for the state. So I'll close with that.
Okay, thank you, Trevor. Thank you, Janice. Thank you, Martha. Thank you, Amber. Thank you, Anne, for all your contributions to this great webinar today. I did note that a lot of the questions in the chat are answered in our report that is conveniently available on chcs.org. So please feel free to check that out. You can also peruse other reports and subscribe to our email updates and follow us on Twitter if you so choose. Thank you everyone for joining us today. Thanks again to all who spoke on the webinar, and have a great afternoon.